Thank you very much. Good afternoon, ladies and gentlemen. Actually, the topic was quite challenging because if you have to discuss both whole body MRI and PET-CT, you easily have a presentation of 3 hours, which of course I will not do. So we take it to the core and what is also the role for the radiologist, and when will you go to whole body imaging? Well, actually, when you have a near established diagnosis of malignant ovarian mass. So not for a doubtful mass, like Professor Thomasin Nagara will show, we have other MRI techniques of that. But when you are very suspicious of malignancy, and what we will do, just what the first presenter said, we will try to confirm the presence of the malignant acnexal mass. Second, assess the tumor burden and do staging for preoperative assessment. And third, not unimportantly, exclusion of a primary site in another like the gastrointestinal tract that can give the metastasis to the ovary. So what are the main aims or challenges that we have? And I put them with a question mark. Can we help in clinical decision making? Can we actually help to plan the surgery? And for Leuven, this is primary debulking versus neoadjuvant chemotherapy with interval debulking. And can we help to optimize the number of R0 resections, complete debulkings, and actually predict optimal debulking? Well, the 2 techniques available, most commonly used for the moment, PET-CT. We all know how this works. It's the injection of FDG, and then the body is actually emitting, and the tumors are emitting the radiotracer, and that's how the metabolic activity will be mapped in the patient with the hotspots on the FDG PET. This is generally very well known. Diffusion MRI, although in use already for a long time, is often the noble unknown person in imaging. How does it work? Well, very importantly, you don't need a contrast agent for it. Actually, a technique was used for the detection of brain infarction, acute brain infarction. What diffusion MRI does, it measures the differences in the movability of your water content. It actually measures changes in the Brownian movement or random movement of water molecules, which is everywhere, your body, a glass of water. So let's put it simple. Here we have a patient with pancreatitis. This is inflammation. Biopsy was performed through laparoscopy, and what we see, no cells, inflammation, a lot of necrosis. So there is a low density of cells and a low density of blood vessels. These are all water molecules, and you can see the green ones are extremely happy. You can ignore the yellow ones because with diffusion MRI, we don't see blood vessels. So the green ones are happy, they can swim around, and there is what we call a facilitation of diffusion. The water can really move around freely. When you have a cancer, this is a pancreatic cancer, you see the chaotic hypercellular structure. Well, it's full packed with cells, and actually, there is somewhere a cell that can move freely, but most of them are stuck. They get depressed, they get hypertension and a red face. And this is what we call restriction of diffusion. How does this translate on the diffusion MRI image? And be aware, this is not the same like MRI. This is diffusion MRI, a sequence that is added to it. Look at the inflammation, not visible. Look at the pancreatic cancer, clearly hyperintense. And there are also some physiological signs. You need to know your anatomy. You would correctly remark to me, hey, I can see the kidney and the spleen. That is correct, because they have a very organized structure with the tubules. Like the kidney, they have the tubules, and you see them on diffusion. But of course, nobody will make the interpretation of a renal cancer there. So just like FDG PET-CT, we need to know our physiology and anatomy. So when we go to FDG PET-CT for staging ovarian cancer, what was the major strength? Mostly lymph node, detection of lymph node metastasis. Like in this study, the sensitivity of PET or PET-CT is truly higher than conventional MRI and CT, and this is mostly important for detecting stage 4 disease. So, like in this case, we see here an axillary lymph node, but also the lymph nodes along the parasternal area, lymph node metastasis through the anterior space, which is a preferred route for ovarian cancer. So nodal spread along the mammary artery chains. What is a potential weakness of the PET-CT? Well, that's for peritoneal staging. We get in general sensitivity of around 79%, specificity of 68%, which is clearly not sufficient to predict peritoneal operability and to assess the complete tumor load. So what are the reasons for a false negative PET? Well, diffusely infiltrative disease spread, which is usually not having a lot of cellular load, so it's difficult to emit sufficient FDG. And it is difficult to make a differentiation sometimes with physiologic bowel activity. Peritoneal implants smaller than 5 millimeter. This is inherent to the spatial resolution of the technique, and then maybe a less frequent tumor, but mucinous tumors don't have enough metabolic activity to be visible. But as a conclusion, FDG PET-CT can be used especially in patients with high suspicion of stage 4 disease, of extra-abdominal lymph nodes, while in really large tumors. Well, in that case, it's for sure useful, but it cannot really predict optimal debulking surgery because of the lower ability for the peritoneum. And this is where we started to think to bringing diffusion MRI. This is actually the same patient. You can see it seems completely negative on the PET, and look at the diffusion. Everything that is white here in the peritoneum concerns a confluent tumor around the liver, but also, very important for the surgeon, around the portal vein. Also here you can see the sigmoid. This is the confluent tumor on the mesosigmoid, and here the tumor is protruding to the wall of the sigmoid. And this is the major advantage that it has. Diffusion MRI is quite difficult to learn, but can go quite fast. We have some physiological activity that we have to recognize. For peritoneal staging, and especially for small peritoneal implants, it is extremely sensitive, with previous reports showing 92 to 95% sensitivity for detecting peritoneal implants smaller than 1 centimeter. But of course, it just doesn't work like that. We need to perform a trick to make it work. Here, on the left side, this was our first healthy volunteer. Is this full with peritoneal carcinomatosis? I hope not. But the small bowel is very tricky for diffusion. The bowel has a high cellularity. It is moving around, so the diffusion technique thinks this is restricted water, so it must be tumor. So we have to help diffusion. What did we do first? We gave water, peroral water, to distend the bowel lumen. We had a problem. There is something called like T2 shine through in water. Sometimes normal water is visible on the diffusion MRI just because it shows so much signal. And there is here a metastatic implantation on the ovary. This is a small metastasis on the left pelvic wall, and this is bowel, no tumor. So we had a problem. So me and Katrijn Michielsen, my PhD, we had to look for the rabbit in the head, and we had to do some magic. And this came under the shape of pineapple juice. And the patients have to drink a complete, around 1 liter of pineapple juice over a 2 hours period before the MRI examination. And we also give an antispasmodic. So the antispasmodic reduces the bowel movement. The pineapple juice is very tasty, so they like to come to the scan. That's an advantage. Second, it distends the bowel, but third, it contains manganese. And manganese works like iron. An MRI is a magnet. Iron makes your image dark. And look at this patient. The stomach is filled with pineapple juice, completely dark. Also, there is suboptimal filling of the small bowel, but look, all these small implants become visible because the background is getting dark. And this is what you have to do to have an optimal workup. Second, also sensitivity, but actually you have to discuss as a radiologist with your surgeon. And this is probably different for every hospital, how the gynecological surgeon will operate the patient. So as a radiologist, you have to be very aware of how are the operability criteria. And what we are trying to do is to predict these operability criteria with the diffusion MRI. So let's go to an example. And this is a patient with ovarian cancer. CT scan for staging, diffusion MRI, and the diffusion MRI always comes with the contrast MRI. So it's not a special examination, it is just a sequence that we have use it in addition to the conventional MRI. Well, it is clear that there is an invasion of the sigmoid and the mesosigmoid. That will still depend on the rest of disease if that is operable or not. But let's go higher to the upper abdomen. CT, nothing apparent. Look at the diffusion MRI. First of all, disease spread behind the liver, between the diaphragm and the liver. But here is more interesting, actually. This is the duodenum and the antrum of the stomach. So the exit of the stomach and D1 segment of duodenum. Actually, there is tumor on the wall of the stomach and the duodenum, and also here posteriorly on the wall of the duodenum and the stomach. And you see on the contrast MRI how the tumor is pulling on the wall of these organs. I think this is really a dangerous thing for surgery, and we have to mention it. Also, according to the Leuven operability criteria, nothing apparent on the CT scan, but behind the portal vein, two extremely bright lymph nodes. Lymph node metastasis behind the portal vein makes surgery, as you know better than me, very difficult. And then also, and probably this was in the past often a blind spot, this is the left portal vein, and this is the fissure along the left portal vein going to the high fissure between the left lobe of the liver and the caudate lobe. Look, hyper intense on diffusion MRI. So actually, there is deep tumoral infiltration along the left portal vein. And this probably, well, I will not say this patient is operable or eligible for surgery, but I will go to with these results to the oncologic board and discuss and hope that the surgeon can make a better decision. So recent studies, what has it shown? Russell Lowe in San Diego has actually been the one and a really hard worker on this technique. He mainly works on gastrointestinal cancer, and so they have that kind of a peritoneal carcinomatosis index, a prognostic score for colorectal cancer. And actually it showed a high match with laparoscopy, surgical laparoscopy, to predict the PCI, and for colon cancer that means operability of a patient with peritoneal metastasis. A very good study from Madrid with Espada and colleagues, actually a very good study published in European Radiology. And look, 91% accuracy for predicting suboptimal surgery in ovarian cancer compared to explorative laparotomy. Our study with whole body diffusion, well, this is the one that I show. We are now at the analysis stage of 170 patients meanwhile, and we have included in the study 360 patients. That shows the high accuracy for peritoneal staging compared to CT and PET-CT, with equal accuracy for detecting thoracic metastasis. And this is very important to go further and apply the technique on the prediction of operability. And where does diffusion MRI make a major difference? Well, it's on the small bowel serosa and colon serosa and mesenteric disease. It is a very good technique to detect metastatic disease on the small bowel and on the colon. And of course, when you would have the possibility of multi-segment intestinal resections, these are patients that are difficult to get a primary debulking surgery. And indeed, we have a somewhat lower specificity. This is absolutely true, but whatever you do, this is the price you pay for pushing a technique to extreme high sensitivities. We cannot avoid it. So, what are the key points for staging it? What are the advantages of this diffusion MRI? Well, a patient that is clearly operable. There is some physiological signal over the bowel, so the pineapple juice did not spread very good over the small bowel. But look here, multiple deposits along the diaphragm and in the right lateroconal space. Well, the volume of it, for sure, operable. This is the primary tumor and the uterus that is also filled with tumor. But what is an additional advantage of the MRI? Well, look at the diaphragm here on the left side. It's a nice black line. Look at the diaphragm on the right side. The black line is completely engulfed by intense tissue. This is macroscopic invasion of the diaphragm, and the gynecological surgeon will have to do a diaphragm resection. So again, we present it to the board, and the gynecologist can decide about the treatment. In this patient received a PET-CT, and that's usually what we get. On the CT, you see a lot of infiltration, but actually you don't know, is it edema, fluid, or tumor? The PET says, not a lot to see, just a little bit here. Yeah, this may be bowel or tumor, the two primary tumors. Well, look to your diffusion MRI. This is a big deposit on the diaphragm. On the right side, there is invasion of the right ascending colon. In the pelvis, actually, it is just confluent tumor around the both ovary, invading the sigmoid. And also here, we have invasion of the colon on the left splenic flexure. Multiple small nodules on the mesentery, no invasion really of small bowel, but then here also in the hepatogastric ligament, multiple metastatic lymph nodes. And probably it will become a bit difficult to really do upfront surgery in this patient. So what we say is unlikely to reach R0 section based on this scan, and of course it's up to the gynecologist to make the complete decision based on what we propose by the imaging. And also, of course, stage 4 disease is an indication not to do primary debulking. So here we have the hypermetabolic lymph node along the mammary chain, and there's really a very bright node on the diffusion MRI of actually of 6 millimeters. So we can see truly small disease. And also here in the patient, because she was not just inoperable because of this lymph node, but you can also see the diffuse disease spread. And this is one of the major strengths of diffusion MRI. So, to conclude in the short, tumor recurrence, because this is maybe more challenging for imaging, but also from the indication point of view. When will you do surgery on a patient with recurrence, or when will you do treatment? I think here we have to be very careful how to apply advanced imaging. And the two major questions that we should ask ourselves: is there benefit of early recurrence detection? Do you help your patient with it? And what actually does your referring physician want, and what does the patient want? And so, as a radiologist, we will never say, do a diffusion in everybody. No, we have to choose our patients very selectively for this technique, and indeed, then I get my Lamborghini out of the garage. But it's not a routine technique. It is a second line problem solver. So, when we look at the PET-CT, it has a good sensitivity and specificity, and mostly the PET-CT is truly better than CT scan, and it allows for a more early and better detection of recurrent ovarian cancer. And that's where we have to put it. Do you want to know all this information? Major advantage of PET-CT over CT? Well, we had to learn it as a radiologist from our colleagues from nuclear medicine. We had to look to this mammary chain. A lot of radiologists forget it. And talk to your radiologist, because often they need to be reminded what are the patterns of disease spread. But look, you can see clearly the bright lymph node. They said here this node was negative. I would not agree personally with such a round lymph node, but you can see nicely the bright spot of FDG uptake on the PET. And then an extremely busy slide. What could be a potential value of diffusion? I make it a bit more simple, actually. Well, we have a study running. It was presented as an abstract. It's submitted for the moment. What it could do again is helping in the operability assessment, just because of the better overview of the peritoneal disease spread. And especially when you look here, of course, not many patients can go to secondary debulking, but of all the patients going to secondary debulking with recurrent ovarian cancer, 93% or 14 of 15 were correctly predicted to be actually able to reach R0 resection, while CT could only do this in 6 of 15 patients. And of course, we need larger data, but this is a slight indication to the potential value of this second-line technique. And again, advantages: bowel disease, better detection of disease on the intestinal structures that help you to make a better decision. So what are the resolution capabilities? This was a patient with asymptomatic increase of tumor marker, CT scan was negative, whole body diffusion was performed, and here you see the small pelvic metastasis of 4 millimeters. And this was confirmed during secondary debulking, and it was a solitary metastasis. No other disease was found. But usually it is the other way around. While the CT cannot really help to guide, well, this is the typical picture of diffuse metastatic disease on the colon and the small bowel. Even on the stomach, we have here the stomach, which is filled with the pineapple juice. This is already a metastatic nodule. This is a metastatic nodule. But look, semi-cystic solid deposits. This is the wall of the stomach. All these small nodules on the wall of the stomach, ascending colon, and also here on the terminal ileum. So actually it's a diffuse visceral carcinomatosis in this patient. And also, unfortunately, a lot of patients present with metastatic disease to the chest. This is, of course, also a contraindication for potential secondary bulking. This patient was still operable by laparoscopy on the level of the peritoneum. So echoendoscopy was performed to be sure that these were truly metastatic, but they were confirmed by pathology. So to conclude, primary staging, the major strong point of FDG PET is nodal staging. And when we look for whole body diffusion, I know it is a technique in development, but it has extremely high capabilities for peritoneal staging. I cannot show data today because we just keep them until final analysis, but there is indeed a chance that we can predict operability or optimal debulking. For recurrent disease, well, FDG PET improved an earlier detection, and again, whole body diffusion, probably more a role to select patients who can have secondary debulking. So we learn a lot from gynecologists, also Dirk and the gynecological surgeons here in Leuven. I learned extreme amount from these people, and it's really great to work together with the division of gynecology here, and that we can develop this kind of technique. I think this is only a proposal. What we are thinking of to try to prove the value of whole body diffusion and actually do a randomized study in patients with ovarian cancer, and actually in one group, the new group, put whole body diffusion up front to select patients for surgery or interval debulking up to the clinical standard that we have now, CT with laparoscopy, with the complete resection rate and survival as endpoint, so disease-free survival. But the Belgian government obliges us also to take into account overall survival, but I would doubt that we make a difference there. I think the most important is if we can improve or at least be with a non-invasive technique equally accurate to predict operability in these patients. I thank you for your attention.
Vincent, thank you very much indeed. Any questions? There's a question from the gentleman there. If the mic could go over there, please. Yeah, perfect.
I have two questions. And the first question is every white spot tumor? What could it be else? And the second question is, what happens to the blood sugar level in the women who take liters of pineapple juice?
You said second? Can you repeat the second?
What happens to the blood sugar level?
Nothing.
Hyperglycemia.
Well, first of all, with the pineapple juice, there is no danger. Of course, we ask the patients if they are diabetic. There are two contraindications, actually. One where we are careful. With diabetic patients, we will in general not give it. That does not mean that the technique is completely useless at that point. I just showed the extremes now. You can still use whole body diffusion without the pineapple juice. The second one that we are a bit careful with, but we ask the nephrologist, are patients with chronic renal failure, and just for the volume overload that you give them and the kalium that comes with the fruit. Actually, what I can tell you, to assess the safety, we went extremely far. The bigger potential danger with pineapple juice is its inhibition of cytochrome P450 in the liver. This could interfere with medication. For that reason, we don't give it to patients that receive targeted therapy, like GIST tumor, Gleevec, we don't give it. These are not these patients in the preoperative setting. Second, we did a pharmacodynamic study with a painkiller that uses that same cytochrome. Actually, there was no effect. For the simple reason that the bromoalin, it is destroyed, because that's the molecule, the dangerous molecule, it is destroyed in the stomach, and it has a molecular size of 36 kilodalton, while that intracellular cytochrome, the liver cells can only allow around 15 to 20 kilodalton into the cell. So we didn't use it just like that. But then if you read the internet on patient sites, patient help sites, they say, my doctor doesn't know, but I love to drink pineapple juice. But it's a big issue with medication. But anyway, like for GIST tumors, Gleevec, we wouldn't use it. But there is no risk for interaction in patients with ovarian cancer. Yeah, the white spots. There was not enough time to explain that. The lymph nodes are a potential problem because you could see all the lymph nodes were white. The white spots in the peritoneum, yes, they are tumor. You just need to know your anatomy of the bowel. The spleen, the brain, of course. For lymph nodes, we go a bit further. So you do, the diffusion MRI also allows quantification, the apparent diffusion coefficient. It's actually a calculation of your gradient, change of gradient. And the lymph nodes, they have a lower ADC when they are malignant, the apparent diffusion coefficient, than when they are benign. That's how we do.